And now I would like to pass the mic to Dr. Alan Steinberg, who will be introducing our master speakers today, Dr. Robert Pynoos and Dr. Alessia Gottlieb. Thank you.
Okay, thank you, Debbie. It's a great pleasure to be able to introduce two colleagues here at UCLA and friends for this series. You know, I was listening to NPR this morning, and somebody made a comment that when somebody says, I'm going to introduce two people who need no introduction, you usually can expect a 30-minute introduction. So I'm going to try not to make that mistake this morning. I want to introduce first Dr. Robert Pynoos, who is professor of psychiatry here at UCLA in our Department of Psychiatry and Biobehavioral Sciences, and director of the Trauma Psychiatry Program. As I think we know, he is co-director of the UCLA Duke University National Center for Child Traumatic Stress. Dr. Pynoos has been a pioneer in the field of child trauma and has made significant contributions over the past 2 decades to our understanding of the impact of children's exposure to violence and disaster, and to elevating the standards of care for children who are victims and witnesses of violence. He's written extensively about child development, the impact of disaster on children and families, and on schools and communities, and certainly has edited a variety of articles and books. Dr. Alessia Gottlieb is co-director of the UCLA Child and Family Trauma Services and co-director of the Child Development Curriculum, and a staff member here at the National Center. Interestingly, she has a really extensive background in journalism and has written for several science series, including WNET in New York, WGBH in Boston, and the BBC in London. So let me leave it at that, and I will turn it over to Dr. Pynoos.
Thank you, everyone, for joining us. Let me just give you a little outline of this period of time. Dr. Gottlieb and I prepared these materials together, but for purposes of time, for this first hour, I'm probably going to be the main speaker, going over the core skills curriculum about understanding the complexity of traumatic experience, reviewing one of our case examples that you have and hopefully have printed out and have in front of you, and going over a sequence of how this may present in treatment that's under the complexity of trauma, the dog bite clinical case. At that time, when questions, Alessia Gottlieb has used many of these materials in training in our child trauma clinic here at UCLA, and would join the discussion in answering questions about how these can be used in a training platform. Let me just then begin. I would ask everyone, this is an area of special interest for me and has been for many years. I would, as you know, the beginning of this says the gateway to intervention. I would ask you for today to probably suspend your consideration of treatment outcomes, of even improved clinical skills in a way, because what I'd like to do is suggest that one of the lifelong career tasks of all of us is to always be increasing our understanding of children's traumatic experiences, both in our vocabulary and how we are able to speak about it, and in our understanding and sharing of that with other clinicians, and in our communication to children and to families. And that's the goal of this particular presentation, to suggest that there are times where even clinical discussions at any of your service sites might not just look at how the case is going, but sit there and ask, what are we now learning, or what have we learned new about children's traumatic experiences that we didn't know before seeing this child or this family, and start to share that among each other. I think that's a key component to improving our care for children and families. I also want to suggest that I'm going to be focusing on a single incident type of trauma, just for purposes of trying to provide some understanding of the concepts of the complexity of traumatic experiences. But we obviously know that most of you are dealing with children who have had serial and repeated traumas. And actually, Esther Devlinser, I think, who is speaking at the next master class in the trauma narrative, has spoken to me about how the experience of a child being sexually abused may very much be different on that first episode, from a middle episode, or even to the last episode. And so really gaining an understanding over time of how the change in the experience is also facilitates doing the work with a child. One of the goals of this is to allow clinicians to really understand what they are hearing and need to maybe hear from a child, what they're not hearing, and allow you to make choices in your work as to what you approach or may not approach for good clinical reasons. So with that in mind, let me just start with the overheads that you have from the understanding the complexity. On page 2, it gives you some of the goals of objectives of this, which is, as I said, to increase our understanding of the complexity, but also to understand the developmental way in which the early organization of memory and learning occurs, because it changes across developmental periods. And that clearly events can't be reduced, as all we know, to a kind of category of saw a murder or sexually abused or was raped by a stranger. There's so much more behind the experience than these terms really capture. On page 3, it's to suggest that the place to start is an understanding of the danger apparatus of the brain, not, as sometimes occurs, by jumping quickly to a sense of the trauma, but to understand that there is a way in which the brain processes danger, and that it is a really important part of the first place to understand the experience of children. Danger takes a priority over normal activities of daily functioning. There is a developmental onogenesis of danger and response. That is, what a 3-year-old appraises as danger and how they think of what's needed to protect them is very different than what a 16-year-old may consider. And experience, culture, family may influence those in many different ways and over time. And then prior experiences are quite powerful in determining some of those choices, even for very young children. The first point of the danger apparatus is to understand that the child is not passive during these experiences. The danger apparatus puts a child on alert and actually makes the activity of the mind extremely, sometimes extremely rapid. Makes the mind of the child active. And the goal of understanding the experience is to share with the child and understanding the activity of their mind during the course of the experience. There are 3 parts to the danger apparatus that I'd bring attention to, or 4. One is there's an appraisal. I know that cognitive behavioral therapy uses terms like thought, behavior, and emotion, but I'd like to suggest to you that behind those words in the danger apparatus is even a greater richness. Appraisal isn't just thought. Appraisal involves all the central input from your vision, from your touch, from your own sense of your rhetoric capabilities, and it is a complicated system of how we appraise a danger, how close it is to us, how it's going to get worse. Children do that at different moments throughout the event, and they do it with different input according to their age. It also means that there are, when it'll be over, misappraisals, mixed signals, things that go on during the course of the event that make it very difficult and trying. There are also powerful, what we call negative emotions. Those don't just include feeling scared, afraid, or terrified, but they include, for example, even by age 3, novel sets of emotions like feeling empathic arousal when somebody else is in danger, hearing them cry of distress and wanting that distress to be somehow answered, having their own heart rates go up in response to that, and feeling that not change unless some kind of intervention happens. It includes what we call negative self-emotions, which includes the shame and guilt, but also cowardliness, feelings of being out of control, and that these often accelerate during the course of the event. Remember, young children are often without caretakers during the course of these events, so the very people that would actually help them with their emotional regulation are absent, or the people that might provide protection are absent. But it also elicits emotions of aggression that sometimes have to be kept in check for reasons of fear that it would only increase the danger to you as a child or to your family. And that includes feelings of revenge or violence towards the person during the course of the event. So some things are kept suppressed, as well as actually experienced more directly. And then lastly, don't just narrow your concept to fear, which is sometimes what happens, but consider that every child and every family member has considerations of prevention and protection, even during the course of the event. At every moment, they're considering what would help at that moment. Mommy coming from the next room, someone coming to help. A teenager, if only I had a gun, I could really shoot them back. Whatever it might be, these are critical parts of the experience. And what needs to be understood is when you think about the experience, when a child is co-constructing it with you, when they go back to the experience, they're not just going back to the objective features of what happened, but they're actually thoughts of intervention will come back to mind at the same time, and one of the richest areas to explore with the child. But again, it's to think that when the event ends, the experience isn't over, because immediately after something's over, you start to think again about how you've appraised the danger. Sometimes you appraise it and realize it was much worse than you were thinking about it during the time. Sometimes with false alarms, you have to quiet yourself down, or with help from parents or family to quiet yourself down because it wasn't as serious as you first thought. You then have, so there are new efforts to emotionally regulate what actually goes on. And this is the world we live in often in our treatment, because as we talk to them, we're eliciting new appraisals, new emotional regulation. But I'd also suggest an large considerations of prevention and protection. New thoughts about how that could be changed and what could make the world safer for the child or for the family. And there are private and public sides to these, some of which you hear, some of which you don't. Parents and caretakers obviously have an influence over this secondary process. Siblings do. Siblings talk among themselves, and adolescents turn to their peer group for many of these considerations. Now, the key to danger becoming trauma is that danger apparatus, which is set up to take action, whether it's to run to a parent for protection, or whether it's to strike back at the person, or whether it's to do something else, to hide, these fail. So in a traumatic situation, that whole way in which the brain's set up to handle danger doesn't work. And there's an experience of it not working. And that means that it's not just a mental event. There's almost always in the course of traumatic experiences moments of real physical helplessness in which you cannot change the outcome or the consequence of what happened and know there's an injurious outcome. And it's actually quite easy to pass over those moments during the trauma narrative, those real moments of traumatic helplessness. We've been referred in our adult clinic many times for adults who have been in horrible traffic accidents in types of CBT treatment, not getting better. And when we see them, we realize that nobody addressed the moment when they lost control of the wheel and what that was like for them. So these moments to attend to them can be very important in doing the work. The other is to understand there's an actual convergence of external and internal dangers. And let me explain what I mean by that. External is easy to understand. I mean, somebody who's bigger than you is doing something to you and injurious, or has a weapon, or is injuring a family member. All the outside kind of dangers you can identify. Internal dangers are complicated. They include, for example, as you'll see, that threats that have to do with the fact that your heart's beating so fast you think it's going to break. The autonomic and arousal symptoms are very difficult to tolerate. That's an internal danger. But it also allows you to take into account the psychosexual development of the child. So a child may have concerns, as we saw a little child many, many years ago who saw his mother raped, and a dildo was used, had thoughts afterwards about whether his own penis can come off and on, what that means. Quite confused as a 3 or 4-year-old. But that's an internal danger. It doesn't relate to the actual violence of having the knife at his mother's throat that he also was contending with. Now, if you turn to page 7, it lists 7 categories about the complexity. I'd say to you that it's important to keep in mind these different categories as you think about and understand of the child, the type of experience that they have had. And know that each of them has their own kind of memory organization to them. It's not just a single memory. And that their own associations and maybe even principles of learning. And that it's part of the reason that memories can seem fragmented or incomplete or even inconsistent when children are remembering. It's not simply an issue that they're dissociating and that they're fragmented afterwards. It's actually a fragmented experience as it's happening And it takes a lot of internal resources to pull it together in a more coherent form, which is what we often do and try to help children and families to accomplish. But it also allows you to know, as you do work with children, to think through, well, what have I heard and understood, and what haven't I? And what may I need to understand better with the child? So let me go through some of the categories. The first is context. It's always to remember that whatever is happening, it's happening at a certain moment in a child's life. It could be that it's their birthday that day. It could be that they were going to be in a play that day. It can be that there was a fight between their parents that morning that really affected them. It could be that they had a difficulty with a boyfriend or girlfriend. There is a context. That context comes with the child into the event. Sometimes it can be a very disillusioning context. Many years ago we saw a child, these are hard examples, but whose mother attempted suicide and actually had told the child who was off school that day that she would play with him and actually had him buy razor blades to help make papier-mâché objects. So he was in a really good mood, only to have her cut herself with those razor blades, feel that he was an accomplice. But the disillusionment of that depended on actually understanding what that day was supposed to be like for him. There are also lots on the minds of the kids, a test the next day that this is interfering with, SATs in college, in high school kids, ongoing developmental concerns that they have about that are happening at that particular time in their life. And these are important because these could jeopardize those developmental trajectories. If we go to page 9, it's saying that the event has many moments to it, and many of you have obviously been doing traumatic narrative work and know that. But it's important to reinforce what those moments are like, that they're moment-to-moment sensual, kinesthetic, body sensations, and that each moment may be very different in those than the moment before. That's one of the reasons why, for example, that so many dangerous circumstances and trauma involve visual input, seeing what the assailant looked like, the kind of facial expression, or how far they are, or where everybody was close to each other, that it's hard to get a child, let alone an adult, to give you that in a verbal form. So drawings, play acting, other things start to get you into the world of the child's experience because it wasn't experienced in a verbal form. Danger's appraisal is very complex that way, so using ways that allow you to understand can be very important with a child. The sounds, remember, sounds are often overlooked. Car accident studies have shown that there's enormous arousal, maybe more than dissociation, are very traumatic because the sound of metal hitting against, has a straight pathway to what we call the startle reflex in the brain, one of the key elements of the trauma apparatus. And there's no protection. You can't put your hands over your ears quickly enough. So that sounds have a real traumatic reminders for children and need to be understood. But that can include comforting sounds of somebody in the ambulance, of parents, of relief. So it's not just the danger ones, but the comforting ones as well. It can also be of actual exchanges and words between people that they hear and take in that may actually feel very threatening to them. Okay, and the appraisals change moment to moment. And your goal is to actually understand how these appraisals are changing. Again, I'm putting it on the understanding. Maybe they were wrong the first time. They thought it was a gunfire and it wasn't. Well, you need to know that because actually that influences somehow how they respond in the future to circumstances. That they're monitoring themselves outside and inside, the internal side, asking what they were feeling at each moment. As I said to one child who said, my heart was beating so fast I thought it was going to break. You need to know that kind of moment as well as what was happening outside the child at that point. And I think that one of the things you need to know is that you're kind of in a very odd way making the child come to terms in this point with the real seriousness and the veridical, the real nature of the danger, because all of us like to bring some changes to that, as I'll talk about later. And it's funny to think that you're actually increasing the tolerance of the child for what really happens. One of the things that happens is that there are developmental failures in expectation that happens in the course of the event. For example, that children, an infant expects that their alarm reactions, crying for help, will actually get help. What happens when that doesn't work? What happens when children and parents who rely on a protective shield that they won't be harmed, that parents can protect them, something that Alicia Lieberman speaks about, fails? What happens when a child feels that they should be able to say no and physically even say no, like 3-year-olds try to do, and they're physically coerced into something? What does that feel like? What happens when they make an assumption that my father or mother or loves me, because it's an internal, but actually the father or mother acts in a way that demonstrates something else? It's a failed affiliate of assumption. It's not just an issue of attachment. And that we have warning systems that tells us something catastrophic may happen, but those fail, and we feel terror at any age when that happens. Or even expecting the world runs by rules, which is what a school-age child does. When they find out rules don't count. And as teenagers, a surrender to feeling that avoidable danger, that there's nothing you can do about it, the sense of resignation, which is so difficult to tolerate. On page 12, I'd like to just suggest that one of the things you'd like to know from a child is that how are they trying to address each moment? That is, are they trying in thought to think of something else? Are they trying to think of controlling their physiological regulation? Are they trying to do it through action? Remember, the brain is set up to deal with action. So the action would be running for cover, pulling the covers over your head, trying to sleep through it that a young child may do in domestic violence, or an older child going to the door and listening but being afraid to go inside because they know if they go inside they might be injured themselves. Or a 16-year-old who tries to get a knife and intervene actually to try to stop his mother from being raped and gets disarmed and feels that he's a failure at even trying to help. On page 13, it's to suggest that that the emotional regulation is hard because in a trauma situation, the emotions accelerate. They go from being afraid to being terrified. They go from being angry to being enraged very quickly. And it's the acceleration that's hard to tolerate, not just the emotion itself. And I think you need to understand that there's different sets of negative emotions. The child may feel shame and wetting or soiling himself, but he may feel guilt at something that he's done or something he's done that may seem irrational, turning one way in an earthquake, as we've seen, having something fall on somebody and feeling guilty about that. That's not the same as feeling of shame that he's wet himself at that point. And that the ways they try to manage emotions before may fail them. If you then look on page 14, it's this, and I hope you'll read through the notes later than from today, it's to say that there's changes in foci of attention. Remember, it's not just one event. So the attention can be drawn away from concern for one's own safety. Even a child's concern for their safety, as commonly as so, for concerns about the safety of a family member. And vice versa, parents being worried about their child. Those are very different experiences, the life threat to themselves and the feeling of life threat to somebody else in the family. They may also have times where the violence comes directly at them, and at that moment they lose thought about anybody else. It's a very strange feeling. It's one that happens in the most loving of families, in a situation where a stranger enters the house or does something. And suddenly the child feels estranged from the other family members. And even the most loving of families sometimes never address those moments without outside assistance. It also means that the moment you get injured, that the concerns that you had to the external danger, looking at what happened, the facial expressions, what I can say or do, whether someone's going to come and help or not, may rapidly change to a focus internally. To a child, it may be about how much they're getting harmed inside when there's physical injury or when there's sexual penetration. That's a very different concern than looking at the face of the person and deciding how malevolent they may be. And during that time, it may be that the child has to inhibit concerns and suppress retaliatory impulses. We often overlook that. The children are not fools at any age, and nor are adults. They sometimes have to suppress the things they'd very much like to do to match the violence out of concern of actually making the situation worse. On page 15, I just put a focus that when you're physically as I said earlier, the physical integrity is violated. It's a very different part of the experience than much of the rest, and it very opens you up to many peri-traumatic responses and desperate thoughts and considerations of protective intervention. But don't just limit it to calling it the child's dissociating if they try to control their sense of pain or their emotional reaction. They're also thinking about, I wish I was in the forest, I wish something else would happen. They have thoughts that accompany that are very important to understand their circumstance. And also they may, in sexual abuse, have very competing thoughts. It's very comforting to remember, sadly, that your father supposedly loves you, even though he's violating you, because it makes you feel less threatened by it. At the same time, you got to disclaim that, because if you start thinking that, you start feeling you're actually participating. So the child's put on a kind of different course, and what happens is they need to be able to get that critical dimension of intimacy, of wanting to be loved back for themselves, but it's inherent in the situation that it's so difficult for them. And then remember that after the event, it doesn't just end with the event being over. Things happen. There's attention to the person who's been injured or to dead family members, sadly. And there's seeking of outside help, the police, paramedics, neighbors. There's experiences of acute medical or surgical care often that have their own sort of organization of memory. And there may be acute separations from family members that are very difficult for children or for the parents themselves. So you need to think that there's that these may that organization of how that memory is formed about those parts of it may be very different than what happened about the event itself. And then there's an additional dimension to the traumatic experience. That is, you don't have to be in the same room with somebody happening. You hear it next door to you and you worry about them. You can hear about it over the radio that something's happened at your children's school and worry intensely about what's happened to them. Worry about a significant other isn't the same as traumatic stress. It isn't the same as traumatic grief, but it has a life of its own and is important to be able to address. It also means that even during the course of an event, for even a 3 or 4-year-old, they may have had prior experiences that are reactivated by a reminder in the course of the event of something else that's happened to them. It comes right back to mind. We tend to want to overlook that, but that can happen quite easily during the course of an event. And lastly, there may be acute grief reaction. Somebody may get killed. You're still under life threat as a child. You know it. But at the same time, your parents not moving. They're not saying anything. You know that something bad has happened to them. So you have a sense of whatever it may mean of loss or something consequence, even while the event goes on. Very complicated. Certainly we see that in wartime. We see that in disasters. But you can see that in domestic violence as well at the extreme circumstances. Okay. So and we have on page 18 a diagram, which I won't go into, about the worst moment. But part of what you're trying to understand at some point is what is the worst moment for a child. We learned very early on that we could go through the whole narrative with a child and say, okay, but tell me what was the worst moment, and they'll put their finger on something, a drawing, something else or tell us about something we've never heard about in the course of that. A child had seen his father murder his mother many years ago, who said that, well, the worst moment was walking by the jail, being in the holding area of the police station, and the parent being in the holding area, and the parent saying, I'm sorry. This just undid the child at that point, and which wouldn't have been heard about if you had only gone through the point of the violence itself. And we have a diagram of what is contained in those moments. I just want to, before I get to the cases, 2 other points. One is, don't think you're getting a journalistic recounting. Journalistic recounting in the third person is actually a kind of traumatic symptom. It's a constricted, unemotional recounting. We use the term remembering with immediacy. There are other terms that people use about it. But don't think even when you're doing that you're getting the full sense of it, because our minds, when it comes to danger, kind of want to weaken it as we speak about it. Want to make the weapon, the proximity of the violence a little less if you're there when somebody else is injured, the lethality, what kind of instrument, how intentional it was. They didn't really mean to do it. It was only, I've heard many adults speak about attempted homicides against their life, and they'll walk into the office and say, well, when the accident happened, but they know it wasn't an accident. So when they speak about it, they're trying to control some of their emotional reactions about the seriousness and intent of it, or the seriousness of the injury. And lastly, one of the things that the intervention thoughts is to have some sense about how you think about them. Children want to change the precipitating event to say, well, if we'd only moved before this happened, or if I'd only unloaded the gun, or if only I hadn't dressed that way that day, or something else. All of us do that in one form or another. To understand those, to get the gun out of somebody's hands, to have the injury healed in some way, to actually get revenge against the person, but safely. A little boy who wanted to wear a costume, it couldn't be seen, and he could take revenge and get away quickly. Or to prevent future trauma by children saying, I want a world where there's no guns and there's no injury in the world afterwards. You need to know that the fascinating thing about intervention thoughts is that they're very developmental. That is, no 3-year-old thinks in a homicide about taking the gun from somebody. They don't think about it. They want superpowers and stuff so that if the knife comes towards them, they can't get injured. 8-year-olds will think about that, but can't do it. 16-year-olds make choices. So that these are changing according to development. But they also tell you about the child's experience. So one of the things you want to do with these is to understand, for example, in a revenge, if a child it's very hard sometimes to let children play out their revenge thoughts. But in that, you're not just interested if they had a sense of revenge. It tells you the amount of violence that they felt that they were under direct threat from. Because the revenge thoughts often match the level of violence, their appraisal of it. It has to match it. So that you need to know what it is so you can understand better the child's experience. Now let me just go to the 2 case examples in this half hour with that as the background. I hope all of you have the complexity of traumatic experience, the clinical case example in front of you. There also comes with an exercise sheet that maybe some of you have done, but maybe had not done before, but could do afterwards in terms of the skill. But we would hope you might do this with a number of experiences that you're hearing from different children in care. Again, independent of looking at what the outcome of the treatment and how it's going. This is a clinical vignette from a 9-year-old boy whose father had unexpected early morning violence on behalf of the actions of his father. Now, and it shows a lot of what I just spoken about. The only background you need to know is that there was a pending marital separation that had not been announced to the children. The father had a level of depression, not clear if it was psychotic depression at that point, that had gone untreated because he had not been willing to seek help. But let's go through the actual experience. The first is his initial appraisal before the personal injury. And let me just read it and speak as I do along. Awakened by his mother's screams, he fearfully imagined that an intruder had entered the house. Now, imagine you're sleeping in a bedroom and he's awakened by these screams. You need to try to understand that he'll make an appraisal. And his first one is not that there's danger from anyone in his house. It's danger from somebody coming into the house. And that's an important moment to understand with him. This was a case that was actually conducted by somebody in training who, over a number of series of sessions, put together this understanding. So it's not all happening in a single session that we're understanding this. This is a composite from those sessions to illustrate the point of the complexity. As he heard shuffling noise in the hallway that moved closer to his door, he felt a lot of fear. So that's his first kind of emotional marker. I felt my heart beating. But then he said, I wanted to shrink back into the wall. But that's an intervention thought. That's the idea that this danger is coming closer. I'm cornered in my room. What do I do? Can I just make myself disappear so the danger can't get me? At first, he did not recognize his father as he entered the room, assuming it was an unknown intruder. And what's his first reaction to seeing his father? Relief. He feels, oh, Dad's here. And he assumed his dad was there to protect him. So there's a moment of relief in this, but that changes very quickly because he sees his father as he gets closer, and his father has this blank look on his face of detachment. And he's never seen his father like that. I want you to know this is a background in which atypical, because many of you see chronic domestic violence, but this father had not acted in a violent way prior to this morning, despite intense marital conflict. So now he sees, and his father's grunting, and the boy uses the term like the sound of a mower. To my mind, it's important to know the lawnmower because he's going to hear lawnmowers in the future, and it's a reminder to him to know that that's what he associated with that grunt of his father, as well as you'll see the face expression of his father that happens that he returns to later on. So he has two thoughts as he realizes this father is very different from the father that he'd known the day before. The first is that he wished he'd had his baseball bat close at hand that he used to keep when he was afraid of robbers when he was younger. And second, he wished that he'd been at a soccer game that morning. It starts really early, so he wasn't in the room. So he's worried about his own self-protection at that point. And then he told us that, and I want you to, again, the point of this is to understand the richness of a child's thinking. He says, I thought if I had the bat and I threw it at my father, if I had, and that he said that, if I didn't hit him and really hurt him, then he would throw the knife back at him that he saw that his father had. And then he said, this is again crazy, and the butt of the knife might not have hit me, the point of the knife might have hit me. My point is how much the child, a 9-year-old, is thinking about that level of danger and calculations about it, even as the event was occurring or immediately afterwards as he's speaking to you. As his father then, physical integrity, the violation, raised his hand as if preparing to strike, the son continued to have thoughts that it was an intruder as well and that his father was part of a conspiracy. It wasn't just his father doing this. And he yelled at his father, "Daddy, stop. Don't hurt anybody. Don't hurt Mommy or his sister." He suddenly had thoughts that, not about his self-harm, but about harm to it. He heard his mother scream about the people that were so important to him. And he then felt very physically helpless. And he could describe that. There was nothing he could do. He just kind of resigned himself. And he felt less fearful at that moment. And then he focuses on the sensation. He can't see this knife entering his head, but he could feel the pressure of the knife, the sensation of the knife. Very different than the moments before. And then his father leaves the room, and all he can see is blood on him. He can't see the injury. But to children, the amount of blood often represents the amount of consequence, especially for younger children. And then he tries to self-talk, tries to tell himself it's not too serious, it's not too serious. Important because in treatments like in CBT, you may help them with self-talk, good self-talk, but that still may be a reminder to him of his effort to self-talk during the course of the event. And then being alone, the violence of father's left the room. Father then, he then starts to yell out, "Mom, can I come out?" A question. "Should I stay? Are you all right?" He kept yelling that with no response. And he said, "I could tell she was hurt, but I didn't think she was dead." And he said, "Please answer." He starts to pray inside. "Please answer, please answer." And then when she didn't, he suddenly started to feel scared again. And now his heart's pounding so loud he can hear it. It's a miss. And he's afraid that she's in shock or hiding, and he wants to run and leave the house, but he decides the safe thing to do is stay in his room. He's afraid that somebody might be waiting outside the door, but all he wants to do to calm himself is hold his mother's hand. A desperate wish and a young feeling of holding his mother's hand. Up to that point, he realized he'd not thought of his sister or getting hurt. He suddenly saw her fly running outside in front of his window, and he felt badly that he totally forgot about his sister. In the middle of all this, he's feeling badly about forgetting about his sister. And then there's a reunion with the mother. Although badly injured herself, the mother came to his room, took him to the bathroom to try to stop his bleeding with a towel. The scene in the bathroom feels strange, and it's an interlude of calm, almost after the violence, and he felt confused. And he says to his mother, "Mommy, who did this to me? Was it Dad?" And she says, "I think so." And this little 9-year-old says to the child psychiatry fellow at that point, "I knew it was Dad, but I didn't want to think so. My mom wanted me not to think that Dad tried to hurt me too." So you can see the struggle over the issues of human accountability and his father being there. It's actually quite conscious to the boy at that point. And as his mother sat on the toilet, he suddenly looks at her face, the the appraisal of the danger through her expression, and sees her as surprised, frightened, and angry. And there's a lot of blood on the towel, but for the first time in the mirror, he can see that he was injured, and he was really hurt, which was a difficult moment for him. His mother put his arm around him as they left the room, and he felt really scared. It's interesting. Of all the moments he defined as the most scary, it was leaving the room, because he's still thinking there's somebody outside the room. And this takes courage. Nothing up to this point took courage on his part. Now he has to muster his courage to go into something that he feels could really be dangerous. And it's a very difficult. The mother calls 911, and although worried for himself, he now realizes that she's seriously injured. Her neck has been stabbed. In fact, it's very, checked on her life was lethal, even though she survived. And he didn't know what to do. Now, how do I help my mother while I'm waiting for the ambulance to arrive? Very difficult. He felt totally ineffectual. The ambulance arrives, the police arrive, and the police ask him what happened, and he tells them. But he says, as he's doing that, he says, I was not proud. A moment of shame about his family, about what it means to have had his father do this, that enters into his feelings at that point, even as he feels some relief with the police being there and being protective. And he has a thought now that maybe his father wanted to die, but he doesn't think of his father trying to commit suicide. But he has a further thought of where his father is and what he's doing. And then afterwards he sees his sister comes back and sees she was injured for the first time, and they're taken to the hospital. Now imagine, this little boy now is going to be sutured, but his mother's not with him. His sister's not with him. He's never been in a hospital, an emergency room. That in and of itself is enough of an experience. But very different than anything that happened before. And his mother, and after he and his sister are attended to, they have to sit and wait while their mother goes to surgery. No family members yet there. Support from the hospital, but not knowing if their mother's going to make it or not. And only later does he find out that his father actually had gone to the back and stabbed himself in a prison hospital. I just want to reiterate two things that came up in treatment that are important from this. Two moments that came up in treatment were, one, he did have supervised meetings with his father many months later, and the only thing that would happen when he'd walk in the room is he'd have to search his father's face to see a different expression on it than he saw that moment of detachment. It was key, but if you didn't know he had that moment of visualizing his father, seeing his father's face, you wouldn't know about that moment that was so important to understand as he saw his father again. The other was that the father kind of didn't try to kill the son. I mean, I don't mean to say it was minor, but he really tried to kill the mother. And it was hard because the family had different appraisals. The children wanted to see the father not as lethally intent as the mother knew him to be. And it was hard for the child to come to terms with the fact that his father really would have deprived him of his mother. But you needed to know the differences in their experience that way. So let me now just, using that, and we can talk about that in the half hour, but I wanted just to use that as an illustration of the complexity. Just sitting back with a case, putting it together, understanding the experience, what you've heard, what you didn't hear. There may have been moments during the course of the treatment that you didn't know about certain moments. Now, it may be that you can decide you don't need to hear them, or that it's very important to understand them. But you need to know from this what those moments are. The moment in which the knife is piercing him. A moment that typically one doesn't get to. We saw a little boy who fell off a ski lift, and he talked about much of the experience. But the moment that he hit the ground from 50 feet up, that moment of hitting the ground was the hardest moment for him to work towards recounting. And it didn't happen from simply going over it again. It had to be understood that might be the most difficult moment among all the others that he had experienced during that fall. If we look at the complexity of trauma, the dog bite clinical case that Dr. Gottlieb used much in her training, it comes from an article he wrote. I want to just go over the overheads, to give you a sense not of how to treat a child. That's clearly what we're about. We're trying to make children, help them with their distress and help them recover. But just to look at the flow, the content flow in a case of treatment, to see how children approach these different moments over the course of a treatment, and how you then can understand that in a natural course of how these moments appear. This is a little boy who was actually bitten by a gardener's dog who was left unrestrained. The boy, for the first time, had actually been allowed recently to play outside in the front yard with a mother in a kitchen window that can see him. And he was thrilled by that and enjoying it. But this dog from a truck across the street ran over and grabbed him by the head, literally pushed him down and bit his head, required neurosurgery, the neighbors used metal garbage cans to fend off the dog. The mother came out and had to separate the dog from him, and it was, as you can imagine, one extraordinarily terrifying and injurious experience for everyone. So he comes into session the first time, and what does he do? Well, he insists his mother stay in the room during the therapy session. You can see that as typical attachment behavior. But it's not just attachment behavior at that point, because the mother wasn't with him on the lawn when this happened. And he wants the mother there as a kind of precondition for safety at this point. And he ties a string to the doorknob and jams doors against the door because he's afraid there could be dogs in the psychiatric clinic area. Now, one of the reasons for that you'd have to know is that during his neurosurgery and afterwards, somebody had the idea in the hospital where they had dogs for companions to bring a dog about to him to make him feel less afraid. So you can imagine what that was like. But now, everywhere he goes, he's afraid a dog's going to appear. So my point of that is to understand that even as he starts to talk with you, there's kind of a preconditions of safety, even for those first sessions, that he needs in place that relates specifically to his experience. The second is it's very common for a child, for that matter an adult, to go to the moment of rescue next, take themselves past the event to the moment of rescue where they're actually put in the ambulance, taken somewhere, police arrive, just as a way of recounting it, because it's the point of over the event and the point of rescue and safety for them at that point. But he runs into trouble when his mind tries to do that, because he immediately goes to being put in the ambulance afterwards. But when he was 6 when this happened, or 5. When he was 3, and with a babysitter, he swallowed a coin, and he was taken by ambulance without his parents to an emergency room, which he found to be one of the most frightening experiences. So when he goes to this point of rescue quickly, in almost the second session, it goes back to that moment. But he's able to communicate that to his mother, who had never understood how difficult that moment had been for him, and how important it was that she was with him in the ambulance on the return on this trip. The next thing he does is that he starts to do checking and reenactment behavior, and I would say in the service of protection. He permits the mother to be out of the room, but frequently checks on her, and then because he's afraid of harm to her by the dog as well. He had experienced the dog, as she tried to separate the dog from him, he had a moment of fear that the dog was going to bite her just as viciously. This is a vicious dog. So it wasn't just, again, attachment. It was embedded in his experience of the dog bite episode. And then it was fascinating. He wanted the mother to carry him everywhere through the hallways, to the office, up high. Now, we came to understand it wasn't just to be carried. He wanted to be higher than a dog could attack him. He was this little creature that the dog was bigger than. So that's the true reenactment behavior, trying to do something that takes account what happened and change the outcome in some way. And it was very helpful for us to understand that with him and with his mother. The next session, he didn't turn to the external danger of the viciousness of the dog, but to his internal dangers. And it really became an issue in his play of how upset he was to have lost control of his bladder and to wet his pants. He just got good bowel control and bladder control, and here he lost it. It was a horribly humiliating experience. But it was more than that, because he started playing with himself and talking about things, and it was clear that this had not been what the dog had done, but he was threatened in his own mind that the dog might bite his penis off. Very typical for a 4 or 5-year-old concern. And that was inside him. It didn't have to do with where the dog's teeth actually were. And again, to help him with that was important in the course of this treatment. He then turned to the external danger. And again, I'm trying to give you the flow of this. Certainly we're trying to do a trauma narrative and be systematic. Because the whole goal of this is to say that if you're going to choose to understand the child's experience with them, to be systematic, but there is an internal psychological soundness by how some of this actually gets played out in the course of working with the child. He then turns to the danger, the actual danger of the dog, and he uses what Anna Freud, if I could be referred to a psychoanalyst, talked about identification with the aggressor, which is the first thing he does is he makes the therapist experience what he experienced. Typical. I've had many children do that over the course of treatment by making me know what it was like to be attacked. Attacking the therapist like a dog, growling, drooling all over her. She's now the one to get it scared inside rather than him. But he's also putting him on the side of the dog. It's better to be in your mind on the side of the dog than on the side of being bitten by the dog. And he starts there. And he jumped at her repeatedly. But it helped her to understand what he experienced. What was the nature of his arousal? What was the nature of his sense of surprise and being frightened that he was communicating to her? Because he knows why he's there, and he's communicating some of that experience directly to her. Then in the next one is that he starts to say, how do you manage your autonomic arousal? Now, we help with skills for that, but look at what the child tries to do. He tries to hide in the office. He imagines a dog in the office while he hid in a box so the dog could not find him. All these things are ways to manage the threat, not only for the consequence, but for the emotional arousal. Nothing here to eat. I'm going now. A dog that doesn't need to eat anything is quite satiated. Amazing that, this little child and all the thoughts they have, but that keeps his heart rate from going up as well. And then, rather than going to the worst moment, at this point, he had neurosurgery and he had a helmet that he had to wear during the recovery where his skull was actually under repair. He now is at a point where he didn't need to wear the helmet. And what he does for the first time is that he approaches his concerns over injury and repair. And there's a little turtle in the office, and he goes and he starts to play with the turtle, with the shell, dropping it off the desk. Will the shell break? And wanting to know that because he now is approaching the fact that he feels physically quite vulnerable. He knows his part of the head missing, and he's without the helmet. But it allowed us to approach that kind of experience of the actual injury and his concerns about its repair. But remember, he's yet to speak about the actual worst part of the violence. But he needs to get through that in order to start to do that, his concerns about his physical vulnerability. In the next session, he then starts. This is, again, things that happen in the course of treatment. But his mother, and don't be critical of the mother, we were able to work this through with her. But when she was young, she had a dog that when bad things happened was her comfort. And she thought one of the best things to do is to get him a puppy and help him to have the comfort of a dog rather than the scary dog. What was remarkable is how he responded to that. He didn't respond just simply with fright. But what he did was he sat there in the backyard, imagining this dog, which was on a leash in the backyard, and always with supervision, is never alone with the dog. But he imagined the dog growing up and getting bigger. And as it got bigger, he would have to claw up higher and higher on his swing ladder set. That's a very complicated thought for a little kid who's doing this very quick calculation of appraisal and reaction and consequence for him. We were able to work that through. The dog was actually kept with relatives until he got more accustomed and worked through his treatment better. And many, many months later, the dog actually came to live with them, and he's actually quite happy with his dog. But it had to be appropriately handled within the course of his recovery. Then the later sessions is he starts to approach the viciousness and helplessness. Very difficult moments for you as a therapist, for listening to this, as well as for him in starting to recount this in his play. He created a scenario and successfully appeased the dog and keep it at bay. But actually then he started to talk about how ferocious the dog was. And he directed the therapist now be a hungry, maniacal dog. Imagine how hard it is for therapists to be put in the place of trying to act like this dog. And he offers the dog food. He satiates, he calms it. These are intervention thoughts. There's something I could do that could quiet this maniacal dog. But at the same time, it gave an opening to talk about actually how vicious he felt the attack to have been. And he actually acted some of that out as an understanding for the two of them. He then didn't go on to this worst moment, but he went on, given the violence that he's now expressed, to talk about his revenge. He knows how violent the dog was. What did he want to do back to the dog? He wanted to pee on the dog's face. He wanted to sneak up and jump on him and bite him all over. Sort of do to him, but it matched the level of violence, both internal dangers and external dangers, that he'd actually experienced. And it's not easy with children, but it's play. They know it's not meant to be revenge, but it's play for them, but it does communicate an enormous amount about their experience itself. And then lastly, he actually starts towards the treatment to start to approach his worst fear. And he starts to play with dolls' heads and tear them off. And it turns out that when the dog had his teeth around his head, he really was afraid as a little kid that his head would be torn off. And that was very difficult for him to communicate. And it was really with the exploration of that he started to actually feel more self-efficacious in the face of danger, and he started to make, not through this play, but sort of contextual discriminations among dogs. Not all dogs are the same. There are certain characteristics of this dog. He could start to make differences between them that allowed him, with his parents' help and with others, to start to re-enter the world where dogs were permissible, but with an understanding of how you make those discriminations. Now, I just wanted to give you a sense of the flow of the complexity. That's very different than putting the case together as the first one, just as a composite. I'd like to point out, if I can, with this last one, that he knew that there was no arrest. There was no charge against the gardener. The mother was very preoccupied. And we were treating the mother at the same time, and you heard about the mother started getting filled with revenge thoughts and got quite depressed because there was nothing happening in terms of even a ticket for having the dog off a leash because they couldn't prove it. And she started, to play during Passover. I started to understand more what they were like because she started escalating her thoughts of what would make him understand, like the feral understanding, till the last thought she had was that this father, the owner of the dog, should have a dog attack his son and feel that that's the only thing that would stop him and make him now keep his dog on a leash, handle things differently. And when we approached that with the mother and worked that through with her, much of her depression and other things really started to lift, and she was a much more active and responsive parent with her child. Okay, let's open this up for questions and discussion, and I please invite Alessia to join me, who's used these cases in clinics, in addition to teaching the actual skills of treatment.
While we're getting while we're getting some questions, we haven't received any at this point. So if you want to give a brief introduction or say a few words, Alessia. Again, the email address to email your comments or questions is for me, Debbie Ling at DLING@mednet, mednet.ucla.edu. That's mednet, like medical network.
You want to say something about using this?
Hi, this is Alessia Gottlieb, and I wanted to mention that both of these cases actually are very valuable in teaching clinicians how to treat and approach families and children who've been through traumatic experiences. From the perspective of complexity, I think although we in our clinics certainly utilize the manualized treatments that are so valuable in treating traumatized children, to understand the complexity of the experience actually allows us to better utilize the manualized treatments because we can really listen more attentively and more actively and better understand what needs to be addressed with utilizing both traumatic narrative comparative work as well as the specifics of the manualized treatment. I think the dog bite clinical case is also very useful because many times child psychiatry fellows and psychologists will ask, well, I can't really get the child to start to talk about what was horrible for them or what was their worst moment. And I think this case really does illustrate how very commonly and typically children will start, again, from a more safe vantage point and move in a somewhat prescribed and very useful, important way through their experiences of the events. And I think this case beautifully illustrates that and helps us understand why the pace and the progress of this therapy is so important in really addressing all the important aspects of the traumatic experience.
We did have one question that was sent in beforehand, which is how can this information be specialized for use with treating groups for girls, or if it can be. And I know we have the UCLA Trauma Grief-Focused Treatment for Adolescents, which is really group treatment as well as individual treatment for adolescents. We certainly have a sense of that, but the trauma-focused CBT has been done in groups for a long time, and CBITS is done in groups. I think the thing that you need to understand is that each member of a group brings in a different level of complexity, and often what happens is that that needs to be appreciated as part of the milieu of the group in terms of how that work is achieved. It also means that one has to be careful about mixing different levels of exposure across mild to very extreme exposures, because actually people that are here have some of the details that have not had such extreme exposure can sometimes be made worse. And also those who have had less mild feel that they can't speak up because it doesn't compare. And those who have had the most difficult feel like they shouldn't speak. So that it does affect the dynamics of group work, the levels and complexity of experience among the group members. It also means they can be support to each other. We run groups where, kids have turned, little kids, grammar school kids have turned and said, well, come on, you had thought you wanted to do something bad to that guy just like I did. And the kid who had not said anything before starts to actually recount some of his revenge thoughts on the support of other children in the group, but done at a particular time in the group. But I think it's also to understand how the group can be supportive of this and appreciate together the complexity of what they're trying to understand and look for sometimes common elements. So if there's a group of children with a similar experience, the group that Chris Lane is here in the room, and he ran a group for children who had adolescents all been shot. And the group experience was one in which they all had a moment where they had to decide to stay with a friend or try to protect themselves. And that was an excruciating, difficult moment. But they all realized that they shared that in common. And that was more their starting point in some ways of really advancing the group work, that there was a shared moment that they had not realized others had experienced within the complexity of what their own individual experiences had been. So I'm just suggesting that those are some guidelines very quickly about some of the elements of this in terms of doing group work.
I don't have a question at this time, but someone has emailed me to tell me that they could not hear me, so I'm going to say my email address for people. It's DLING@mednet, mednet.ucla.edu. And
I think I'll make one more comment about the group, the group work for the working with children. Certainly one of the things that we come across commonly in working with children who've been through a traumatic event is that in spite of their world or life experience, they still feel oftentimes that they are the only one who has experienced this particular event. And I always find what I've always found remarkable in working with children is just a little bit of indication that, in fact, they're not the only ones who've experienced this, even by saying something like, you know, I've worked with children who have experienced something and felt this way, and they'll say, me too, I feel this way. That happened to me, after having not been willing to offer that information initially. And I think one of the potential benefits of working in a group setting is that, along with all of the other benefits that Bob Pynoos mentioned, also for children to understand that they are not alone in this experience and that there are other peers. Of course, peers are so important to children. Other peers who have experienced, if not the same event, but similar feelings and fears and thoughts about their experiences.
First of all, the individual who made the group question, so thank you for your comments. That was great. And we have one more question. How did the therapist in the dog bite case initiate play therapy? Did she simply ask the boy to act it out, or did they utilize specific toys?
Well, the person had a number of toys in her room, and they were just a collection of toys, and the child chose some. She didn't specifically choose things that had to do with the dog bite. And he, you know, the issue here, many of you see children who come in after they've been through a lot of serial and repeated and chronic trauma, where it's more difficult and challenging sometimes for the child to start to approach it. In an acute situation, what I was trying to say about the danger apparatuses, the brain is doing all this. It's going over things. It's trying to change things. It's trying to deal with protective intervention. So you can expect a child, actually, to start to engage in play that has some relationship to what's just happened. And that it's your job to kind of think that way. I mean, you know, I know that Judy Cohen and Tony Manarino and Esther in their trauma-focused CBE talk a little, essentially putting narrowing your vision in terms of your attention to what is the traumatic communications and the traumatic narrative work. But you have to kind of think that way as you start to see a child. If it's there and on their mind, in their play, what are they actually doing? And starting to address, we would argue that, and all of you can discuss this, that one of the best ways to help children, to engage them in this work, is to address their intervention thoughts. It's not to deal with it as a journalist, but their intervention thoughts, to allow them to act them out, to help them with them, to say, boy, don't you wish that could have happened. And sometimes in doing that, you're giving them a lot more support that they actually start to talk more directly about some of the moments as they then go on to play it out in different ways. If you're not attentive to the fact that there are these intervention thoughts, then you can feel very stymied in wanting a child to be able to do some of the trauma narrative work. And again, I would ask all of you to think through and share with each other the goal of understanding and continuing to understand the work with children as you build a vocabulary. For example, many times we see children come in with an experience that you may not have been seen before or know. Well, what do you need to know about that? We would hope at some point to have case examples on our website that gives you a place to go to think about certain types of experiences as you approach seeing a child. The example I would give you is a child in a car crash, a 4-year-old, a 3-year-old. After seeing a number of children, you learn that, well, one of the hardest moments for them is they can't get their seatbelt on because their mother has been knocked unconscious as the person who would have done it. But if you don't know that moment may be there, you may actually not be able to approach that moment with the child. So thinking through the experience, sharing the experiences you've heard from other children and from other clinicians and getting a vocabulary about that, I'm suggesting again is an independent skill set from actually learning the skills and the variations in how to do trauma narrative work or different portions of any manual protocol. I had a question about how do you talk about the worst moment in a group. Well, again, Chris Lane is here and has done probably more group work than I have that way. But one of the things is that part of it is some psychoeducation about what worst moments are during the course of group work, and to let them know that there'll be a time to be able to approach those, to start to, even using adolescents, you can use charts and other things to actually do it in a somewhat homework way of the priorities of what hierarchy of what their moments were, start to see what the differences of those moments might be among each other, to get some appreciation of that among them. But it is a point of revealing and vulnerability, I think it's behind that question, which is really very difficult for different age groups. So school-age children, it may be the shame part of it. In adolescents, it may be the sense that, we've treated lots of boys who've gone through things of that they, that they were unable to do anything at that point. It knocks their sense of masculinity at that moment. You have to start to address some of the sense of vulnerability in order to succeed, but it sets up a milieu of acceptance and tolerance within the group that allows you to approach those. And that's a good part of the dynamics of doing the group work. And you have to keep working at that sense of tolerance and acceptance among each other, because those moments to be expressed are very, and if it's dissimilar from a different age period, sometimes you won't hear. So we work with children, adolescents who've been shot, who had actually been molested when they were younger. And that wasn't something, they were all talking about getting shot. They didn't want to bring up that earlier event in that particular group under that particular setting. And the therapists were respectful of them, had private sessions and could refer them to some additional help. So it is to understand from a clinical point of view what you're going to achieve within that group and what portions of other life experiences may or may not be as approachable in that particular group setting, and to do that in a careful and clinical fashion.
We have several questions, actually. So this comes from Jeff Gold from the Arizona Department of Corrections. When the victim uses an expression such as "when the accident happened," as you used in the example, does the therapist want to address this as a cognitive distortion?
Well, good questions, but let me step back. I know the terms are out there like cognitive distortion. The importance of what I was trying to say about weakening the version and allowing something else to happen, dealing with the issues of human accountability, is it's not only cognitive. It involves a whole set of reactions within the person to want to call it an accident, because the tolerance of feeling that someone really wanted to kill you is a very difficult moment. So it's easier to call it an accident. In a clinical setting, I don't know in a corrective setting as much, but in a clinical setting, we would actually say at some point, I think it's easier to call it an accident. And a statement like that, not a question, why did you call it an accident when you know it's not, actually often allows, as is true of many principles of psychotherapy, much more content for the person to speak of than trying to point it out to them or correct it. And so it is to understand why somebody might be doing that, to say it's, it's easier to think of somebody having, accidentally hurt you than to think about what it was like for someone to really try to, intend to do that. People will often go at any age. I've had 4-year-olds say this to me, and I didn't say quite those words to them, or adults. Yeah. And they really will say that, and that then allows you to proceed a little further. The old days that was called I don't think cathexis, but a kind of emotional release, but it does address those moments, but it does so in a respectful manner of why they're having to use them in the first place.
This is a question from Karen Talon Brown. I work in a very rural, remote area, and there are rarely any mental health professionals to serve very young children who experience trauma or traumatic bereavement. What can we do to help parents and paraprofessional educators when children have these needs? This is about infant, toddler, preschool age kids.
Well, I hope it's a national network that will be able to help even more than any answer I give today. I think the Alicia Lieberman's and Early Trauma Treatment Network, along with many other network partners, are trying to address those and to work through how do you think back from what we would do in treatment to what are really the things that can help parents or others when there aren't clinicians as available. One of the things that you want to do is to help. The complexity of trauma helps in a number of ways. Just understanding that in communications with parents, even with very young children. First of all, it allows you, like with this little boy, to say to them that each of you had a different experience. If the mother was there at the time, we worked with a mother and child where he was injured in a playground. And the mother's experience was very different from the child. So you can help parents to understand that their experiences are very different, and it may lead to different sets of reactions. Not only the age difference in them, and that it's been challenging to both of them, because as Alicia Lieberman says, usually as young children there's been a fracture in that protective shield. And to be able to tell parents, so what we often with parents will say, so tell me what your experience had been. What did you understand? When did you first hear if you weren't there? What were you afraid of? What it was like to see your child? Get the set, I really felt awful that I wasn't there to protect my child. And then to let the parents set of reactions allow you to understand with them what their children's reactions were. Not so much to do the assessment of the child, but actually to do the assessment of the parent and say, if you felt so bad at not being able to protect your child, I'm sure your child may have felt the same, that they wished you could have been there to protect them. You both have a challenge to kind of build that back with some confidence after what happened. And it's to know in the midst of this that we're not talking about today. One of the other key skills is understanding traumatic reminders and how they work. But the more you can understand from a parent, even about the objective features of the event, the actual circumstances, some of the things the child may have said to the parent in relating it, can start to build up a vocabulary with the parent about some of the reminders and cues to which the parent can be a valuable assistance. And parents for young children are extraordinarily important to emotional regulation. Example I give is when there was a civil unrest in Los Angeles, and children who were on one block saw things burned on the next. When they walked to school, they could smell the ashes for months, and their heart rates would go up. But the parent, because they had been afraid the fire was going to come and burn their house, it was going to come to them. And what they needed a parent to do is to know that that was happening and take the child's hand, very young children, keep their heart rate, let it come down a little. But a parent needs to be helped with that. You can do that anywhere in this country, under any circumstance, perhaps not as completely if you don't get a chance to do some of the more therapeutic work, because part of doing trauma narrative work isn't, I don't think the concepts necessarily like desensitization or other things are what we're going to end up using, but it certainly allows you to understand the cues in the child's life to which they may need help from parents, from others, to help themselves. And with young children, those cues are very different than they are for older children sometimes. So that's an answer a little about how to, and if the parent wasn't there, it's to let the parent know that in very young children that the child's experience was that serious. Because the parent knows it but doesn't know it, not having been there, and needs to be kept so that they know that they can keep it in mind when they need to in terms of how the child's doing in their daily life, because it's easy if you weren't there actually then at some period of time to overlook what had happened. And that's important for young children as well, to have a parent's understanding of that. It comes out of an appreciation of this complexity.
I was just going to make one additional comment related to the working with very young children who've been traumatized. It's also very important to consider what the parent experiences as well, not just in the past, but also in the present. I think of an example from an accident that we had here in Los Angeles related to a car accident which involved several people and parents with toddlers and infants in their arms. And I was called to the emergency, to the intensive care unit because one of the mothers of the toddler who had been injured was climbing into the crib in order to sit next to her 18-month-old who had serious injury after being after flying out of the mother's arms when a car hit them, and as pedestrians. And what we had to understand as physicians and staff in the hospital was that it's not just the child who's also trying to to regain the shield of protection, but also parents oftentimes of infants, preschoolers, and toddlers also are attempting to also reconstitute that shield that they feel is such an important part of who they are as parents. So one of the things we're working on here is trying to get out very quickly are some of these kinds of concepts that we will make available through the web in the form of questions